Imagine a patient presenting to emergency department with sudden severe onset of abdominal pain that is so intense that the patient cannot even lie still. In today's video, I am going to discuss such a surgical emergency, that is perforated peptic ulcer, with a complete clinical case presentation. Hello everyone and welcome back to my YouTube channel. This is Dr. Asma, and in today's video we are going to discuss a clinical presentation on perforated peptic ulcer, and the video is going to include history, examination, investigations, management and key learning points in the above mentioned case. Starting with the history, patient's profile. My patient Ali, a 48-year-old male office worker, married, is permanent resident of Rawalpindi, and he presented to emergency department on 25 June 2025 at 9 p.m. with the chief complaints of severe generalized abdominal pain since 6 hours. So, coming towards the history of presenting illness, he was apparently well with 6 hours prior to presentation when he experienced sudden onset of severe epigastric pain described as stabbing or sharp in nature. The pain was initially localized to epigastrium but then rapidly became generalized across the whole abdomen. It was severe with a score of 10 by 10 and did not relieve upon medications or change of posture, and there were no aggravating factors. The pain was associated with nausea and one episode of non-bilious projectile vomiting that was foul-smelling and had undigested food contents and did not have any mucus or blood in it, and it was also associated with inability to tolerate any oral diet. There was no history of trauma. Importantly, the patient reports a long-standing history of dyspepsia characterized by burning epigastrium related to meals, partially relieved by over-the-counter antacids. He also admits a frequent use of NSAIDs for his lower backache. There was no history of hematemesis or melena and no prior abdominal surgeries. Rest of the systemic inquiry was unremarkable. His past medical history was insignificant, with no history of diabetes or hypertension or previous hospital admissions or liver diseases. His past surgical history was insignificant, although his drug history may include regular NSAID use, over-the-counter occasional antacid use, but no proton pump inhibitor usage was mentioned. Upon personal and social history, he is a chronic smoker with 20 packs per year, occasional alcohol intake, mixed diet, he drinks filtered water, he had anorexia, decreased sleep, altered bowel habits, and no urinary complaints. On general physical examination, my patient appears toxic and distressed with GCS of 15 by 15. He was well oriented of time and space and lying still in the bed due to pain. Vitally, his pulse was 110 beats per minute. He was tachycardic. His BP was 100 by 60 millimeters of mercury. His respiratory rate was 24 and he was afebrile with a temperature of 98.6 degrees Fahrenheit. Upon abdominal examination, his abdomen was distended, boat-like rigidity was present, generalized tenderness was there, rebound tenderness was positive, and bowel sounds were absent, significantly telling us about paralytic ileus. Per rectal examination, he had empty rectum and no blood or melena was present at the time of examination. Based on the history and examination, our provisional diagnosis is perforated peptic ulcer with generalized peritonitis. The differential diagnosis may include perforated appendix, acute pancreatitis, perforated typhoid ileitis, and mesenteric ischemia. However, the sudden onset of pain, the rigidity of abdomen, and the peptic ulcer disease and the classic findings of examination strongly favor perforated peptic ulcer disease. Investigations include laboratory investigation, that is complete blood count that shows leukocytosis, serum electrolytes showing hyponatremia and hypokalemia, serum amylase is mildly raised, and arterial blood gases may show metabolic acidosis in severe cases. Imaging includes erect chest X-ray that shows free air under both hemidiaphragms, and then abdominal CT scan may show pneumoperitoneum, the site of perforation, and free intraperitoneal fluid. Management is done aggressively, and the initial management includes nil per oral, 2 wide-bore IV cannulas, aggressive IV fluids, nasogastric tube decompression, IV proton pump inhibitors. The definitive management includes emergency exploratory laparotomy or laparoscopy, identification of the perforation, Graham's patch, omental patch repair, peritoneal lavage, and drain placement. Post-operative care includes continued antibiotics, PPI therapy, gradual reintroduction of oral food, and H. pylori eradication once the patient becomes stable. The complications include septic shock, intra-abdominal abscess, wound infection, anastomotic leak, and multi-organ dysfunction. The prognosis depends on the time to presentation, patient's age, presence of comorbidities, and degree of peritoneal contamination. Early diagnosis and prompt surgery significantly reduce the mortality rate. The key learning points in this video were that the sudden severe abdominal pain with rigidity is a red flag, and always consider perforated peptic ulcer in acute abdomen. X-ray chest is a significant and valuable investigation in such cases, and early resuscitation and surgery save lives. That concludes today's video, and if you found this video helpful, please like, share, and subscribe to my channel for more exam-oriented videos and case discussions. This is Dr. Asma signing off. Keep watching, keep learning, and keep saving lives. Thank you.